the demo session that is going to be displayed now. Dr. Sonal is a quiz master for today's session. So madam will give you certain instructions and we will have a 3 to 4 question demo quiz. You have any doubts, you just post in the text box so that we know if you have any challenges in answering. The actual quiz session will start after this demo session. So please call upon your colleagues too to participate in the session. Good number have registered. Maybe they will join after 7 o'clock. And this, whatever we're going to have, is only a demo session, demo quiz. So few instructions are there. Madam will let you know. And the question will be displayed on your link. The options also will be displayed. You will have the opportunity to pick up the option. And that's your noted. Okay. So over to Dr. Sonal for further proceeding. This is only demo. Once the original quiz starts, we will give you again further instructions. Sonal, can we go with the demo?
Yes. So good evening, everyone. I will give you few demo questions. Basically the quiz will have totally 6 rounds. Today's quiz, which will comprise of 10 questions in each round. And the rounds will be of basic science, CKD and dialysis, general nephrology, glomerular disease, clinical case solving, and transplantation. So you'll have to log in with your credentials, with which you have already registered. So you have to log in with that, and the questions will be displayed in serial order, and it will be seen in this insert video. And the quiz master will explain you the question, and after which the timer will start. And once the timer starts, the login area displays the question with the options on it. And the time allotted is 30 seconds. And you'll have to select the correct option. And once you select it, you just click on the submit button. Once you submit, there will be a short of thank you. After that, you cannot change the question. So you have to be very sure before you click the submit button. And if you want a dry run, we can show a few questions. So the question would be like...
dry run curling is, Sonal. We will give the dry run now.
Okay.
After that, we'll go for the original questions.
But the backend people would be... Do you have this questions already?
Yes, ma'am. Yes, ma'am.
So this is a question for a dry run. So the question is, calcium oxalate crystals in the urine may be seen in all of the following conditions, except option A, Crohn's disease, option B, vitamin C ingestion, option C, ethylene glycol ingestion, option D, Fabry's disease, and option E, celiac disease. And the timer will start, which will run for 30 seconds. So if you are ready with your answer, if you are sure about your answer, you can click the submit button, and that will be then final. You cannot change it. So be sure before you submit it. So the time is up. And after this, the answer will be given. Once you have submitted, everyone is submitted. You cannot submit it afterwards. And the answer is Fabry's disease. Giving you one more question for the dry run. Which of the following drugs has not been shown to cause direct crystalluria? Option A, ciprofloxacin, option B, indinavir, option C, orlistat, and option D, trimethoprim. And your time starts now. So before the timer gets over, you have to submit your answer. So time is up. And the correct answer is orlistat. So if anyone wants more questions, we can give. Otherwise, I think things should be clear on this. and there will be explanation after that, and then there will come a next question. Manjusha ma'am, you have any instructions to be given?
हाँ सोनल वही लिख रही हूँ मैं chat box में.
Hmm.
The audience who have joined are apparently for the demo is about 25 number, but original registrations are about 79 in number. So
Hmm.
probably people will join after 7 or something like that. I'm not sure. It's exactly 7. But what I'm wondering is the people who are right now in the quiz for the demo, if they have any doubts, they can post their doubts in the text box on their screen so that the technical team sees and let us know the question. Vipul, any question is posted, any doubt is posted by the audience?
Can they raise their hand and the tech team can then?
No, we cannot see anything, Sonal. Only the tech
No.
team can probably
If the
see
tech
that.
can,
Actually, ma'am, there is they haven't posted any comment or questions.
Okay.
So when they'll post, I'll surely update.
No, let them at least post they're good to go. I mean, no issues. Bolke, please post. No, if there are no issues, please post that you're good to go with thumbs up sign. And please ask your friends also to join so that we start this session in another 5 minutes. It's very user friendly, very delegate friendly, and very PG friendly too. Not the thoughts type of questions I'm saying, but then the mode of answering is very comfortable for all of you. Nevertheless, in another 5 to 7 minutes, we start the actual quiz session and madam will give you all the instructions. Please follow them scrupulously and tell your friends to join because there are good number of registrations for our quiz, but I see only less than 30% who have joined. Kindly call up your friends to join the quiz. We have certificate of participation for this quiz as well. And also people who win are going to get the certificate of winning too. So please don't miss the opportunity.
so this is just 7, so maybe like
Yeah, another 5-10 minutes we can
can
we'll
wait for
wait,
5-10 minutes.
Sonal, because good registration, so there maybe at least 50% is expected to join.
Mhm. We will give the instructions again once everyone joins. So when we start the quiz again, we will give all the instructions.
Yeah. Another 5-10 minutes we'll wait, and then you can project the slides of instruction as well, Sonal, if you have. You've already made the slides as well, no? So you can project those slides too, if you have. Or
So
you can send it to Siddharth.
I'll stop sharing this demo one and I'll just start the final one.
हाँ
I'll
ठीक
just keep it ready. Yeah.
ठीक है, अच्छी बात.
Tech team, Vismay bhai,
Yes, sir.
I just need to ask one thing that whether the messages that are being posted on chat of Zoom, does the participants can see that?
No, no.
Is there any, we can do anything so that they could see?
Can the
Because
technique copy and paste on the audience side? The one which Manjusha ma'am has written, you can copy and
yes,
paste.
yes. That is what I'm trying to say, ma'am, to the team. We can do that?
No, no, sir.
No. Okay.
Then how do we interact with the audience? क्या बोलता है? No issues, ma'am. Let's go. Okay. Let's go. Okay. What is this? No, I mean, how do we ensure that the audience sees our messages? Because they have an issue, we need to understand. If they have any problem, we need to address that too. It's user friendly, but nevertheless, we can't expect everybody to be seeming quite friendly. Some may have some issues. People, let us know if there is a further increase in number. Taki once we reach 710, I think we should start off the actual session.
So, ma'am, total attendance is 33 and live users are 30 as of now. And there have been, yes, this is
30.
Yes, so 35 people have joined.
okay.
हाँ जी, क्या चीज?
35 have joined and 33 are the live users. And
हाँ.
yes, yes,
We'll
that's
wait
it.
for a few more minutes. Yeah, no problem.
Okay, okay, okay. The total registrations have been increased to 82. So,
82 पर
yeah,
पर join किए so
total attendance is 37 and live users are 35.
वो डिफरेंस क्या होता है लाइव यूजर्स और अटेंडीज का मतलब क्या है? मतलब कोई लोग पार्टिसिपेट नहीं कर रहे? व्हाट डू यू मीन बाय लाइव यूजर्स एंड नंबर?
Vismay bhai,
हाँ,
I'm asking the tech team.
ठीक है.
Okay, so 36 people are waiting.
हाँ, those people are ready to take the quiz है ना?
Yes, yes.
पर हमारा नंबर ऑफ रजिस्ट्रेशन तो 82 है बोल रहे हैं आप.
हाँ, टोटल 82 रजिस्ट्रेशन है, लेकिन 36 people are waiting.
हाँ ठीक है. जब ओपन किए, जब ओपन करते हैं, नहीं, इट्स ऑलरेडी ओपन. ओके ओके, राइट.
Yes.
We wait for another 3 minutes, Sonal. Is it okay?
Yeah, it's okay.
Yeah, yeah. But whatever we are speaking, I think the audience is able to hear, right? So I
Yes, yes.
think,
Yes, yes.
yeah. I mean, whoever has joined right now live on the channel, please tell your friends to join off immediately, because we had good number of registrations, but we see around 50% who have joined, 50% who have not joined. So please call up your friends and tell them to join.
Because if they join late, they would lose the marks
They
of
would
the
lose
first
marks.
round.
Yeah, that's what.
So if
You're
you can,
waiting already for 10 minutes.
if you can attend maximum number of questions, you would get the best,
Marking also will be better. Yeah.
best chance to win.
With 7:10, we would start the a minute to go. 7:10, we would start the actual session.
Yes.
Shall we start, Sonal? If you're ready, I'll just give the brief introduction and then we go ahead.
Yes, we start.
So, good evening, everyone. Welcome you all for this annual quiz by Women in Nephrology India. As you know, Women in Nephrology India has been conducting monthly academic activities for the benefit of the fraternity, including the faculty as well as the trainees. This session is completely dedicated to the trainees. We all know that the trainees have recently given exams and who are also preparing for the exams are well prepared to take the quiz. This is the national annual quiz that Win India does, and every time it's been Dr. Sonal Dalal who leads the team and has been doing a wonderful job to enlighten and empower the students from the scientific perspective. So without much ado, I'm glad to say that this year we had a good number of registrations as far as the quiz is concerned, reaching up to 80 plus, but then we need to see 80 plus participating in the audience link too. So we await the same. But without much ado, I hand over the further proceedings to our quiz master of today's session, Dr. Sonal Dalal, who is a senior consultant nephrologist from Gujarat. She's also executive member of Win India and Win India. So over to Dr. Sonal for further proceedings.
Thank you, Dr. Manjusha. Good evening, dear students. Today we will have our annual quiz, which is it will include all the different aspects of the nephrology, and the quiz. The rules of the quiz will be: it will have 6 rounds with 10 questions of each, and there will be total 60 questions. The rounds will comprise of basic science and nephrology. There will be CKD and dialysis, general nephrology, the round on glomerular disease, one round which will be on the clinical case solving, and the final round is on transplant. The students, you'll have to log in with the credentials which you have registered yourself, and the question will be displayed in a serial order in a insert video, and I will explain the question, after which the timer will start. Once the timer starts, the login area will display the question and the options, and the timer will be for 30 seconds. Once you select the correct option, you have to click the submit button on that option, and once you submit, there will be a message which will be "Thank you for submitting," which will be there for the brief period, and after that the further correction will not be possible. So before you submit, you will be 100% sure that you want to submit the same option. The results will be displayed at the end of each round, and you would receive a certificate. For first 3 winners, you will get a certificate of winning, and most other will get the participation certificate. So I wish you all the best, and I think with this we'll start with our first round, that is of the basic science and basic sciences and nephrology. The first question in the first round is: the radius of the split pores in the glomerular basement membrane is 1 nanometer, 2.5 nanometer, option C 3.6 nanometer, and option D 4 nanometer. Your time starts now. Time up. The correct option is option C. It is 3.6 nanometer. Next question, question number 2. The fluid leaving the glomerulus normally has a specific gravity of option A 1.001, option B 1.010, option C 1.020, and option D 1.030. And your time is on. Timer. And the correct option is option B. It is 1.010. Question number 3. Which of the following immune response is specific to transplantation? Option A, indirect allorecognition. Option B, activation of innate immune response. Option C, direct allorecognition. And option D, activation of adaptive immune response. Time starts now. Timer. And the correct answer is direct allorecognition. So that is when passenger leukocytes and dendritic cells form a donor organ. They travel and there is a direct allorecognition. So that is the primary. The question number 4. Urinary bladder is visible as a distal end of Wolffian duct. At which age? Option A, 4 weeks. Which age of gestation? 4 weeks. Option A is 6 weeks. Option B is 4 weeks. Option C is 5 weeks. And option D is 7 weeks. Timer. And the correct answer is option C, at 5 weeks. Next question is question number 5. Polar cushion is formed by option A, macula densa, option B, intraglomerular mesangial, option C, Berlin cells, and option D, extraglomerular mesangial. Your time starts now. Timer. The correct answer is option D, extraglomerular mesangium. Question number 6. Medullary rays are formed by all of the following except option A, loop of Henle, B, distal tubule, C, proximal tubule, and D, collecting duct. Your time starts now. Time. The correct answer is loop of Henle. Question number 7. Proteinuria occurs by all of the following except A, defect in structural protein of slit diaphragm by number and location. Option B, increased podocalcin expression. Option C, podocyte injury effect on the glomerular basement membrane. Option D, defect in glomerular endothelial cells. It is except. Timer. The correct answer is increased podocalcin expression. This will not cause proteinuria. Now, question number 8. True about vasopressin is option A, more sensitive to small changes in blood pressure. Option B, more sensitive to small changes in osmolality. Option C, more sensitive to small changes in blood volume. And option D, stimulant response curve is not exponential. So, time starts now. Time up. The correct answer is it is more sensitive to small changes in osmolality. Next question, question number 9. HCO3 reabsorption in the proximal tubule is enhanced by option A, chronic hypokalemia, B, low level of angiotensin 1, option C, low PTH level, and option D, all of the above. Time up. The correct answer is option D, all of the above. So bicarbonate is affected by all of this. And last question of this round, question number 10. Which step is not required for T cell activation? A, positive co-stimulation. B, engagement of T cell receptor with MHC complex. C, interleukin-2 transcription. And D, engagement of Toll-like receptor. Your time starts now. Time is up. The correct answer is option D, engagement of Toll-like receptors, which is not required for the T cell activation. So with this, we are end of our first round, that is of basic sciences. Would the tech team like to give scores at the end of first round?
Vipul?
Yes,
Vipul, are
ma'am.
the scores ready at the end of first round?
Tech team, can you please tell the score after the first round?
Just a second.
Only first 3 or first 3, if you can tell, that is okay. Or maybe if you just have a chart, which is
Yeah, chart you can display of everybody's.
Ma'am, I just put that in a chat box.
chat box. So
Not show the screen. Can we
at
not
the
show the
first
screen?
position, it is then he'll have to share the screen. It will be difficult.
Okay, okay, right. You can announce, Sunil.
The first position is Niranjan. Second is Mithun, and option third is Mithun J, and second is Mithun A. So it's very good and great beginning. Keep it up and try to maintain the position. And others, you please try to uh, see to that you can do better than them. So all the best, and let's start with our second round. So the next question, next round is our dialysis and general chronic kidney disease round. The first question in the second round is, if you consider that daily phosphate intake is 1000 and 60% is of this 1000 is absorbed, and in 3 dialysis per week HD patients, how much phosphorus is needed to be removed approximately by the phosphate binder despite HD? Option A, 357 milligrams. Option B, 457 milligram. Option C, 257 milligram. And option D, 157 milligram. How much phosphate has to be removed by the phosphate binder in spite of 3 times a week dialysis if you have a 1000 milligram daily consumption of the phosphate? Your time starts now. Yes, the time, the option, correct option is option C, that is 257 milligrams per deciliter per day. Next question. 4TS score is used in the CKD and dialysis patients to predict option A, vaccine efficacy following COVID vaccination. Option B, drug-induced immune reaction. Option C, cardiovascular mortality. And option D, heparin-induced thrombocytopenia. 4TS score. Your time starts now. Time up. The correct answer is it predicts the heparin-induced thrombocytopenia. Now the next question is question number 3. All are true regarding fat-soluble vitamins in CKD and dialysis except option A, vitamin E losses are minimal in dialysis and supplementation is not advised. Option B, patients on hemodialysis have a subclinical vitamin D deficiency and supplementation is recommended. Option C, the daily requirement of vitamin C is 120 milligram in CKD patients. And option D, vitamin K promotes vascular calcification. You have to choose the wrong answer, that is, accept the fact. The time starts now. Time up. The correct answer is option D, vitamin K promotes vascular fraction. That is wrong. It prevents vascular calcification. Question number 4. A 45-year-old woman with end-stage kidney disease from hypertension is on dialysis, would like to start an exercise regime to become healthier. You advise that exercise program done during dialysis compared to exercise between dialysis session is more likely to result in which of the following? Option A, it increases the peak oxygen consumption. Option B, decreased likelihood of dropping out. Option C, improves exercise time. And option D, it improves the perception of health. Your time starts now. Time up. The correct answer is it decreases the likelihood of dropping out. So there is this study which is cited and it shows that intradialytic training program in hemodialysis patient, it is associated with less dropout and it's much better than others. Question number 5. Icodextrin, about icodextrin, all is true except option A, it is preferred for the fast transporter. Option B, it improves the osmotic efficiency across the small pores. Option C, it leads to false positive results on glucose testing. And option D, its molecular weight is 17 kilodalton. Your time starts now. Time up. The correct option is molecular weight is 17 kilodalton. Next question, question number 6. Which of the following beta blockers overdoses is not treatable with dialysis or renal replacement therapy? Option A, atenolol, B, acebutolol, option C, nodelol, and option D, propranolol, which is not removed by the dialysis. Time up. The correct answer is option D, propranolol. Propranolol is not removed by dialysis. Next question is question number 7. A 44-year-old woman on CAPD with 2.5% dextrose 2-liter exchanges is present to your clinic with new onset shortness of breath and pain in on breathing. A chest X-ray shows right-sided pleural effusion and a diagnostic tap is done. Which one of the following tests is suggestive of peritoneal pleural leak? Option A, higher LDL level in the pleural fluid compared to the serum. Option B, higher protein levels in the pleural fluid compared to serum. Option C, higher glucose level in the pleural fluid compared to serum. And option D, no difference in glucose level between the pleural and between pleural fluid and serum. Time up. The correct answer is higher glucose level in the pleural fluid compared to serum. Very easy answer, because as we know, it has a dextrose in the pleural fluid and it will be seen more in the pleural fluid as compared to this. The pleural fluid glucose is high as compared to the glucose in the serum. Next question is question number 8. 1 gram SPS resin binds potassium by option A, 0.8 to 1.7 milliequivalent, option B, 0.5 to 1.2 milliequivalent, option C, 0.3 to 1.7 milliequivalent, and option D, 0.6 to 1.8 milliequivalent. 1 gram of SPS resins. Your time starts now. Time up. The correct answer is 0.5 to 1.2 milliequivalent. It displaces about 2 to 3 milliequivalent of sodium and this much of potassium. A 54-year-old man is started on a CAPD, and he before 6 weeks. And when you ask PD nurse to perform a test to evaluate the peritoneal membrane, that is PET test, to prescribe appropriate PD therapy for this patient, which one of the following is mostly used test in this incident? Traditional PET test, fast PET test, modified PET test, and dialysis adequacy and transport PET test. Time starts now. The correct answer is traditional peritoneal equilibration test. Basically, it is there is no much evidence to suggest that one test is superior over other, but this traditionally the test which was introduced by Twardowski in 1987, it is the most widely used, and it requires 2 to 4 hours and is much better compared to the others. So this is what is the most recommended test. If this above patient is on CAPD with 2 liters of 2.5% dextrose with a dwell time of 4 hours and traditional PET test 5 weeks after initiation of PD, and the following values were obtained, wherein DP creatinine is 0.91 and D upon DO glucose is 0.2. Which one of the following PD prescription is appropriate for him? Option A, CAPD with 2 liters of 1.5% dextrose solution and dwell time of 4 hours. Option B is 2 liters of 2.5% dextrose and dwell time of 4 hours. Option C, APD with 2 liters of 4.25% dextrose and dwell time of 1.5 hours. And option D is APD with 2 liters of 2.5% dextrose and dwell time of 1.5 to 1.5 hours. How would you prescribe this patient for the PD regime? Time up. The correct answer is APD with 2 liters of 2.5%. So basically this patient is a fast or high transporter, and so he will be benefited with APT with shorter dwell times, that is 1.5 hours or less. Rapid transporters have a high rates of diffusive transporter for the small solutes, and so that's why he will be benefited from this regime. Now we will go to the third round. Before that, tech team, if you can get results of the second round.
Tech team can kindly share the result, please.
The result at the end of the second round is at position 1, we have Vaishnavi. At position 2, we have Ravina. And at position 3, we have Deepa. So we have 3 completely new participants from the position 1. So that's very good going. So congratulations to all 3 of you, and all the best for the next rounds to all the participants. So with this, we start our third round, that is of the general nephrology round. The first question in the third round. Following drugs can be used to treat lithium-induced nephrogenic diabetes insipidus. Option A, spironolactone, B, eplerenone, C, amiloride, and D, all of the above. Time starts now. Time up. The correct answer is option C, amiloride. Next question. True about urine anion gap is except is all then except. Option A, a positive urine anion gap generally between 20 to 90 is usually indicative of renal etiology like renal tubular acidosis. Option B, results near zero, that is between plus 20 to minus 20, cannot be reliably interpreted. Option C, ketoacidosis has no effect on urine anion gap. And option D, urine anion gap is unreliable in neonates. Your time starts now. Time up. The correct answer is option C. That is, ketoacidosis has no effect because actually unmeasurable anions in ketoacidosis will affect the urinary anion gap. So it is important on effect. Question 3. Medullary sponge kidney occurs due to cystic dilatation of option A, proximal collecting tubule, option B, distal collecting tubule, option C, collecting duct, and option D, loop of Henle. Your time starts now. Time up. The correct answer is collecting duct. Basically, medullary sponge kidney is originally called Dendrosy Kaposi disease, and it is congenital disorder characterized by the malformation of the terminal collecting duct. And this collecting duct dilatation or ectasia is associated with formation of both small and large medullary cysts. Next question, question number 4. Nephronophthisis associated with cerebellar dysfunction is known as option A, Senior-Loken syndrome, B, Joubert syndrome, C, Gabert syndrome, and option D, none of the above. Time up. The correct answer is option B, Joubert syndrome. It is an autosomal recessive disease. It's characterized by cerebral vermis hypoplasia, ataxia, polydactyly, hypotonia, developmental delay, neonatal respiratory dysregulation, and abnormal eye movements, and nephronophthisis, which is a renal manifestation. Question number 5. Pain in obstructive uropathy. It depends on rapidity of obstruction, option B, degree of obstruction, option C, cause of distension, and option D, all of the above. Time up. The correct answer is rapidity of obstruction. Question number 6. Which antibody is associated with increased risk of scleroderma renal crisis? Anti-RNA polymerase 3, anti-centromere, anti-U1-RNP, anti-topoisomerase. Your time starts now. Time up. The correct answer is anti-RNA polymerase 3. Next question. Identify the picture. Which crystals these are? Indinavir, acyclovir, sulfa, none of the above. Urinary crystals. The correct answer is acyclovir. Next question, question number 8. All are true regarding the Fidelio trial, except Finerenone is renoprotective in patients with diabetic kidney disease. it has a option B, it has assessed kidney fibrosis as an endpoint. Option C, Finerenone has inverse agonist action on mineralocorticoid receptor. Option D, Finerenone is safe in CKD compared to Abiraterone. Your time starts now. Time up. The correct answer is it assesses the kidney fibrosis. It does not assess the kidney fibrosis. It just assesses the GFR decline as compared to the placebo, but directly biopsy is not done and fibrosis is not assessed. Next question, question number 9. All drugs are currently being tested in trial for retarding the kidney fibrosis. All are, which are all these drugs except option A, trametinib, option B, lademicirin, option C, prizolizumab, and option D, ninatinib. Your time starts now. Time up. The answer is prizolizumab. Question number 10. Which of the following is false regarding roxadustat? It is orally available HIF-PHI. Option B, it reduces iron absorption irrespective of CRP level. Option C, it reduces the hepcidin and increases the endogenous EPO. And option D, it is less incidence of hyperkalemia and metabolic acidosis. Time up. The correct option is less incidence of hyperkalemia and metabolic. So there is some incidence of hyperkalemia which has been noticed. So the correct answer is that. So with this, we come to the end of the third round, that is general nephrology. Can we have the results at the end of third round?
Tech team, can you please give the results in the chat box?
So at the end of third round, we have first position. It is Ramavajula Anitha. Second position is Deepa. So Deepa has moved from third position to second position. And at third position, we have Ravina. So Ravina has fallen by one step. So all the best to everyone and congratulations. Let's move to the fourth round now. The fourth round is for the glomerular diseases. Question 1 in the fourth round. Regarding the serological assessment of anti-GBM disease, which of the following is most correct? The detection of circulating anti-GBM antibody is essential for the diagnosis. The detection of ANCA does not influence the outcome or treatment. Anti-GBM antibodies are detected in up to 5% of the SLE patient. And option D, antibodies to laminin 521 are found in more frequently in patients with lung hemorrhage. Your time starts now. Time up. The most correct option is option D, antibodies to the laminin 521. These are found frequent in patients with lung hemorrhage. We move on to the second question of the glomerular disease. Ophthalmological evaluation in patient with suspected glomerular disease would help in all of the following except option A, C3 glomerulopathy, option B, PAX2 associated renal disease, option C, collagen fibrotic glomerulopathy, and option D, Fabry's disease. Time up. The correct answer is collagenofibrotic glomerulopathy. In C3 glomerulopathy, we get drusen. In PAX2, we have renal coloboma syndrome. In Fabry's, we have corneal diseases. So in collagenofibrotic disease, we don't have this. Question number 3. 35-year-old Caucasian man is referred to nephrologist for hepaturia occurring following an upper respiratory tract infection with normal other general examination. His GFR is 100 ml per minute. Urine analysis shows hematuria and proteinuria. And spot urine protein to creatinine ratio is 0.4. A renal biopsy is done and it shows no specific lesion on light microscopy and negative immunofluorescence. And based on this EME, electron microscopy image, which one of the following is the most likely diagnosis? IgA nephropathy, Alport syndrome, autosomal recessive Alport syndrome, and thin basement membrane disease. Option B is X-linked and option C is autosomal recessive. Time up. The correct answer is thin basement, as you can see in this image. Question number 4. Prophylactic full dose anticoagulation to be considered in glomerular diseases with serum albumin less than 2 to 2.5 in all of the following patients except where the proteinuria is more than 10 grams per day. Option B, when there is a BMI of more than 30 kg per meter square. Option C, when there is a recent orthopedic or abdominal surgery in these patients, or in patients who are having genetic predisposition of thromboembolism. Your time starts now. Time up. The correct answer is option B, that is 30. As per KDIGO, it is more than 35 kg per meter square is the indication for the prophylactic anticoagulation. Next question is question number 5. In a 6 years female with IgA nephropathy, score of M1E0 S0 T0 with proteinuria of 1.8 and creatinine of 0.72. All of the following can be advised except salt restriction, option B, RAS inhibitors, option C, avoidance of corticosteroids, and option D, lifestyle modification. Your time starts now. Time up. The correct answer is option C, avoidance of corticosteroid. There is evidence derived mostly from the retrospective studies, which suggests that the treatment with corticosteroid leads to improved kidney survival in children with more than 1 gram proteinuria. So it has to be given along with RAS blockade and other treatment. Question number 6. 22 years male with a primary FSGS and urinary albumin creatinine excretion albumin creatinine ratio of 5.2 milligrams, 5,200 milligrams per gram, was started on 1 milligram per kg of prednisolone. After 5 weeks of therapy, his USCR is 20 milligrams per gram. So how will you taper steroid now once patient is in remission? Option A, straight away start tapering corticosteroid. Option B, taper corticosteroid after 1 week. Option C, taper after 2 weeks. And option D, continue high dose prednisolone for 16 months from starting. Your time starts now. Time up. The correct option is option C, that is taper corticosteroids after 2 weeks. As per the guidelines, continue high dose corticosteroid treatment for at least 4 weeks or for 2 weeks after the disappearance of the proteinuria. Question number 7. Block phase scanning microscopy is used to study all of the following except option A, 3-dimensional structure of the podocyte. Option B, good view from basal aspects of the podocyte. Option C, good view from the luminal side of the podocyte. And option D, better understanding of the subpodocyte space. Your time starts now. Block phase scanning. Timer. The answer is option C, good view from the luminal side of the podocyte. The luminal aspect is seen with routine transmission scanning, routine transmission scanning electron microscope, but block phase scanning is used to look at the podocyte from the basal aspect. Question number 8. Which of the following is not a part of International IgA and risk predictor tool? Option A, Oxford MES score. Option B, BRACE. Option C, eGFR at biopsy. And option D, immunosuppression used after biopsy. Your time starts now. Time up. The correct option is option D, that is immunosuppression used after biopsy. It is not considered in this. So now we move on to the question number 9. As per advocate study group, Evocapan was used recently in trial for which alignment? Option A, FSGS, B, MPGN, C, ANCA-associated vasculitis, and D, SLE with DPGN nephritis. Time up. The correct answer is ANCA-associated vasculitis. The C5a receptor inhibitor Evocapan is been used it is studied in the treatment for ANCA-associated vasculitis. Question number 10. Which of the following is not associated with FSGS? Option A, Epstein-Barr virus. B, lithium. C, increased lean body mass. And option D, NPHS1 mutation. The time starts now. Time up. Very easy question. It is Epstein-Barr virus. It has nothing to do with the FSGS. So with this, we come to our end of our third round. And now we move on to the fourth round. And we'll go to the clinical cases. Before that, can we have the winners at the end of fourth round?
Tech team, can you please show the winner list in the chat box? Ma'am, it is displayed on the chat.
It is, yes. At the end of round 4, we have at position 1, we have this Rama Vajula Anitha, same. At position 2, Deepa again. And at third position, we have K. Soundarya. So congratulations, all 3 of you, and wish you all the best again. So now we move on to our 5th round, that is of the clinical round, which is case solving. Case number 1. This is a 56-year-old male with a chronic lymphocytic leukemia. It presents to an emergency room with fatigue and complaints of body ache. The lab shows hemoglobin of 8, WBC 67,700, platelets at 1,50,000, creatinine is 0.7, potassium is 4, and plasma potassium level is 5.6. Serum potassium is 4 and plasma potassium is 5.6. And the patient is not on any medication. He is initiated on normosaline infusion at 75 cc per hour. What is the cause of elevated plasma potassium? Option A, pseudo hyperkalemia. Option B, shifting of potassium out of the cells. Option C, resolving acute kidney injury. And option D, reverse pseudo hyperkalemia. Your time starts now. Timer. So the correct answer is reverse pseudo hyperkalemia. Basically, reverse pseudo hyperkalemia refers to a false elevation in plasma potassium with normal serum potassium. This is most commonly seen in hematological malignancies, and it is due to the heparin-induced cell membrane damage, and it can also be result from the mechanical damage to the cells during the transport. Case number 2. An 18-year-old male has a persistent hyperkalemia over last few years. He has several direct family members that also developed hyperkalemia at the young age. His physical exam reveals blood pressure of 160/80 and heart rate of 78 beats per minute. On examination, he has a short stature and some dental abnormalities. He has some degree of intellectual changes during school. His lab data reveals serum potassium of 5.7 and metabolic acidosis. What is the most likely cause of this hyperkalemia? Option A, Bartter syndrome. Option B, pseudo-hypoaldosteronism type 2, that is Gordon syndrome. Option C, Gitelman syndrome. And option D, pseudo-hypoaldosteronism type 1. The time starts now. Timer. The correct answer is option B, pseudo-hypoaldosteronism type 2. There is a mutation in WNK4 and K1 kinase and are most commonly the cause of this. While there is an increase in plasma potassium concentration, normally stimulates aldosterone release from the adrenal gland, and plasma aldosterone levels are generally low in this disorder. So these patients usually have short stature, club feet, and stiff joints, and they present like this. The third case, A 47-year-old man with resistant hypertension is diagnosed with primary hyperaldosteronism from unilateral adrenal adenoma, and he opts for a medical treatment over adrenalectomy treatment. And it is he started on spironolactone 50 milligrams per day with good control of his blood pressure. Compared with medical management, surgical treatment would have decreased his risk of developing which of the following? Chronic kidney disease, diabetes mellitus, hyperkalemia, and hyponatremia. Time up. The correct answer is chronic kidney disease. Basically, mineralocorticoid therapy for primary hyperaldosteronism is associated with higher risk of developing CKD, which surgical adrenalectomy appears to mitigate this risk. Case number 4. A 30-year-old woman with presence with nausea, vomiting, dysuria, and flank pain. On examination, her temperature is 103 degrees Fahrenheit, blood pressure is 80 over 41, and her heart rate is 120 beats per minute. She is admitted to the medical intensive care unit for further treatment. Based upon the SMART trial, resuscitation with Ringer's lactate solution instead of normal saline is most likely to result in which of the following? Option A, increased risk of hyperkalemia. Option B, increased risk of hyperchloremia. Option C, decreased risk of major adverse kidney event. And option D, increased number of ICU free days. Your time starts now. Time up. The correct answer is decreased risk of major adverse event. Usually we feel that it is hyperchloremia. Basically, the SMART trial found that critically ill adult patients, balanced crystalloids as compared to the normal saline led to lower rate of major adverse kidney events defined as composite death from any cause, new renal replacement therapy, or persistent renal dysfunction. So this is the correct answer. So case number 5, a 25-year-old male, he's a bodybuilder presents for a nephrology evaluation after being found to be having elevated creatinine of 1.8 on routine screening. He has no past medical problem. His blood pressure is 125 over 76 with heart rate of 78 beats per minute. His examination is unremarkable, and he uses anabolic steroids daily for bodybuilding. So the remainder of his labs show 1 gram of proteinuria 24 hours and no hematuria. Kidney biopsy is most likely to show which of the following in this patient? Bile acid nephropathy, acute interstitial nephritis, FSGS, or minimal change disease. Your time starts now. Time up. This is easy. The correct answer is FSGS. There have been many multiple different mechanisms of injury from anabolic steroids, including secondary FSGS, post-adaptive glomerular changes, bile cast nephropathy, and ATN. All has been reported, but his presentation is like FSGS, so the correct answer is FSGS. Question number 6. Two sisters having aging 14 and 16 years, they were diagnosed with C3GN. A mutation in the gene encoding which of the following is most likely? Option A, C3 nephritic factor. Option B, factor H. Option C, C1. And option D, MASP. Your time starts now. Correct answer is option B, factor H. Of the listed things, only factor H mutation have been associated with genetic C3 gene. C3 nephritic factor is an autoantibody that binds to and stabilizes C3 convertase, and it is cause of acquired C3 gene and not genetic C3 gene. C1 is a part of classical complement cascade and not the alternative complement cascade, and MASP is a part of lectin pathway. So correct answer is factor H. We move on to question number 7. A 70-year-old woman which was referred with a 6-week history of painless macroscopic hematuria. Her only medication were IM Gold and oral ibuprofen, which she took for a rheumatoid arthritis. Her investigation shows serum creatinine of 1.2, urine dipstick blood 4+ positive, protein 1+, abdominal plain X-ray and ultrasound KUB are normal. Which one of the following is the best next step? Option A, cystoscopy. Option B, intravenous urogram. Option C, renal biopsy. Option D, stop ibuprofen. Option E, stop sodium orothiomycin. Your time starts now. Time up. The correct answer is option A. See, basically in this patient, if he's because of ibuprofen, it will cause interstitial nephritis and there will be painless hematuria. It will not be a painful hematuria. Gold also will cause proteinuria more, and if present on its own, it is unimportant, but it can also cause a membranous gene, but not a macroscopic hematuria. However, most likely with macroscopic hematuria, it is important to exclude the bladder tumor. So it is necessary we should go for a cystoscopy rather than a biopsy. Case number 8, a 38-year-old woman with biopsy proven FSGS has a serum creatinine of 2. 24 hours creatinine clearance is 48 ml per minute. 24-hour urinary protein excretion is 3.7 grams. Her GFR using iothalamate as a marker of true GFR is 32 ml. Which of the following mechanism explains why the creatinine clearance overestimates the true GFR in this patient? Option A, decreased reabsorption of filtered creatinine. Option B, increased release of creatinine from muscle. Option C, decreased tubular secretion of creatinine. And option D, increased tubular secretion of the creatinine. Your time starts now. Time up. The correct answer is option D, increased tubular secretion of creatinine. The tubular secretion of creatinine occurs in all patients, but it is higher and more variable as renal function declines. So as GFR declines, will be more variable. This overestimation may be as great as 10% to 20% in individuals with normal renal function and 40 to 100% in patients with azotemia. So renal tubular reabsorption of creatinine does not occur, and increased release of creatinine from muscle occurs in muscle injury, rhabdomyolysis, but not likely in this patient. Case number 9. The measures to prevent AKI in patients with traumatic rhabdomyolysis include all of the following except A, urine output should be maintained around 300 ml per hour until creatinine kinase level is less than 1000. Option B, urine output should be maintained around 300 ml per hour until myoglobinuria disappear. Option C, mannitol is beneficial because of diuretic, antioxidant, and vasodilator property. And option D, mannitol can prevent renal tubular cast deposition, expand extracellular volume, and reduce extra compartment pressure, muscle edema, and pain. Measures to prevent AKI. Your time starts now. Time up. The correct answer is you have to maintain the urine output above 300 ml per hour, till the CPK is less than 1000. This will prevent the AKI in patients with rhabdomyolysis. Last question in the clinical round, question number 10. Which of the following findings on electron microscopy best describes the pattern of light chain deposition disease? Option A, dense intramembranous sausage-shaped deposit. Option B, punctate powdery electron-dense deposit. Option C, random non-branching fibrils. And option D, parallel hollow microtubules. Timer. The correct option is punctate powdery electron-dense deposit. This is the characteristic finding of light chain deposition disease. On light microscopy, patients will have a nodular mesangial sclerosis, and on IF, there is a linear staining with either kappa. The presence of random membrane non-branching fibrils suggests amyloidosis, and parallel hollow microtubules that are larger diameters are diagnostic of immunotactoid. So with this, we come to our end of our clinical round, and then we will move on to the last round of transplantation. Before that, end of the 5th round, can we have the results, please? At the end of 5th round,
Tech team, can you please show the result?
yes, the results are there.
Okay.
At position 1, again, Rama Vajula Anitha. At position 2, Deepika is continuing with her position. And at position 3, it is Dr. Mithun. So Dr. Mithun has now again bounced back. So congratulations to all 3 of you, and that's great. Let's now move on to the last round, that is transplantation. Question 1. Which of the following trial has been tested sequential double induction protocol and tacrolimus monotherapy in kidney transplant recipient? Option A, Osaka. Option B, Advance. Option C, Harmony. And option D, proof of concept trial. Double induction protocol followed by a tacrolimus monotherapy. Time up. The correct answer is proof of concept trial. The proof of concept trial of a sequential double induction protocol based on alemtuzumab, which reduces the number of effector T cells, and the anti-TNF monoclonal antibody infliximab, which targets some of the donor-specific memory effector T cells, which is followed by the tacrolimus monotherapy. It showed excellent 5-year outcome even in patients who are T cell sensitized. Question number 2. Elevated donor-derived cell-free DNA levels are seen with one of the following condition, except in all of the following condition, except 1, chronic allograft nephropathy. Option 2, immediate post-transplant hours. Option C, acute pyelonephritis. Option 4, acute tubular necrosis. So time starts now. Time up. The correct answer is chronic allograft nephropathy. Donor-derived cell-free DNA represents an average of 0.34% of total DNAs. And kinetic palette study of donor-derived cell-free DNA after transplant showed high median level of immediate post-transplant, that is around 20%, which is rapidly decreasing after that first day, and around 5%, and then stabilizes below 1%. But levels are increased during acute rejection and to a lesser extent in pyelonephritis and ATN. So the correct answer is chronic allograft nephropathy. Question number 3, find the odd one out. Sirolimus S. hygroscopicus. Option B, voclosporin, Tolypocladium inflatum. Option C, Mycophenolate mofetil and Penicillium moldus. And option D, Tacrolimus and S. tuberculosis. The time starts now. Which one is the odd out of this? Time up. The correct answer is voclosporin and Tolypocladium inflatum. This is the odd one out. Next question, question number 4. In the treatment of nocardiosis, all of the following drugs are useful except erythromycin, linezolid, tigecycline, dapsone, and minocycline. The time starts now. Time up. The correct answer is erythromycin. It is not. Macrolides will not be useful. Rest are useful. Question number 5. All are true for belatacept except option A. It inhibits T cell CD28 activation and proliferation by binding to co-stimulatory ligand. Option B. It initiates phase dosing. Initial phase of dosing is 10 milligrams per kg on day 0 pre-transplant, and then on day 5 week 2, 4, 8, and 12. Option C, maintenance dose is 5 milligram per kg. And option D, dose reduction is required in renal impairment as per the creatinine clearance. Time starts now. Time up. The correct option is option D, dose reduction is required. So dose reduction is not required. There is no dose changes as per the GFR. Question number 6. All of the following viral infections are associated with post-transplant malignancies except EBV, option B, HCV, option D, HHV, that is human herpes virus, option D, human papilloma virus, and option D, cytomegalovirus. Association with malignancy. Time up. The correct answer is human herpes virus 3. That has no connection with the malignancy. Question number 7. The postulated mechanism for accommodation in ABO incompatible graft in renal transplant, ABO incompatible renal transplant. All of the following are a postulated mechanism for accommodation except option A, accommodation might involve in changes in antibodies. Option B, change in antigen. Option C, complement inhibiting factor. Option D, modified control of complement. And option E, acquired resistance to injury. Time starts now. Time up. The correct answer is option C, complement inhibiting factor. It is not required. Question number 8. In acute antibody mediation 6 months post-transplant, which one of the following treatment regime should be initiated? Option A, high-dose intravenous immunoglobulin. Option B, plasmapheresis and intravenous immunoglobulin. Option C, plasmapheresis and bortezomib. Option D, bortezomib. Your time starts now. Acute antibody-mediated rejection. Time up. The correct answer is plasmapheresis and IVIG. That is the gold standard which has been recommended. Question number 9. Which of the following increases the likelihood of remission with plasmapheresis treatment in recurrence of FSGS post-transplant? Option A, presence of living unrelated kidney transplant. Option B, age less than 40. Option C, initiating treatment within 2 weeks of the diagnosis. Which has the best chance? Your time starts now. Time up. The correct answer is initiating treatment within 2 weeks of the diagnosis. Sooner you start, better you get the response. Within 2 weeks, if you start recurrence, the response rate is much better. And the last question of the quiz, the BAMF human organ transplant B-spot panel, a molecular test of diagnosis renal graft rejection, FFP renal tissue is listed. How many genes? Like it lists 450 gene panel, 770 gene panel, 80 gene panel, or 120 gene panel. Sorry, I forgot to start the timer. B-HOT panel, molecular test to diagnose the renal graft rejection. Time up. The correct answer is option B. The FFP renal tissue, it listed 770 gene panel. So with this, we end our quiz. Can we have the results?
Tech team, can you please show the result?
So we will have the final results now, right? At the end of round 6, yes.
Yes, ma'am.
So thank you so much, everyone. I think it's been an amazing participation over the last hour and a half from everyone. And we have seen a little variable result as well as consistent result. I think the tech team should give the final cumulative one of all the rounds. Who is the winner, the final winners of 1, 2, 3, not just the round 6. We want the cumulative winner now of all the rounds. So I think they may take another 2 to 3 minutes time for them to do it. But nevertheless, I'm sure all of you have enjoyed the questions, and Dr. Sonal has put in a lot of efforts to bring in almost every every area of nephrology, like starting from basics to transplant. It's not a easy task. It's definitely a humongous and an arduous one, which has taken it, and she is the one who is the art of quiz conduct in almost all the conferences, and I'm sure a lot of knowledge has gone to you through the participation in the quiz. The other entity that we had said at the outset itself is that in this quiz participation, we are planning to give the certificate of participation to everyone who has participated, because those who have participated in the quiz will get the e-certificate rather than those who have registered, because the registered numbers are not equivalent to the participant numbers. And of course, no need to mention about the certificate that will be given for the winners, number 1, 2, 3, who will stand in the first place, second place, and third place. And this will be emailed to your personal mail IDs as you have registered through the website, through the link that has been given to you. So we are sure that you also have enjoyed the conference, and I'm sure the academic activities that are being undertaken by Win India are equally interesting and encouraging to everyone. And we reiterate and reemphasize, it's not just for women students or something like that, because I've seen women acing the 1, 2, 3 positions in all the rounds. It's for everybody. So please spread the word that all the sessions of Win India academic activities are for both men and women for a good participation. That is for knowledge sharing rather than anything else. So do we have the final result, Vipul and tech team, of all the rounds together?
At the end of round 6, still the same, that is Rama Vajula Anita is at first, at second position Deepa, and at position 3 it is Ravina.
But the total cumulative one, I think we need. Of all 6 rounds, what is the total cumulative score? Probably we need that.
Yeah. Ma'am, tech team, can you please share the cumulative score for all the rounds? Who are the top 3 from all the rounds?
Top 3 doesn't mean that only top 3 have done well. So, I mean, everybody's participation is definitely important. Here and there, missing out on options during MCQ is quite normal. But then going back and confirming, and Dr. Sonal has put in a lot of efforts to give you an evidence-based answer. So going back and studying the same, and of course, certain clinical questions which are of day-to-day clinical importance to us, pertinence to us, that also please go back and read, so that, you know, I mean, you are more empowered and strengthened from that angle of nephrology. So winners doesn't mean the others are not winners. Everybody is a winner in this quiz conference. Only that somebody have scored a little more than the others. So to encourage everybody, we are giving the certificate of participation. Tech team, can we have the final results?
Ma'am, they have shared on the chat box.
पूरा इकट्ठा का मतलब
yes, it is. They are saying it is same as round 6 because they are calculating on the cumulative basis, I think so, from starting.
So this
at the end of this round, at the end of the quiz, the cumulative result, top 3, at number position 1 we have Rama Vajula Anita. She is at number 1. Congratulations. At number 2 we have Deepa KP. Congratulations, Deepa. And option at number 3 we have Ravina. Congratulations, Ravina. So these 3 they have the students have done well, and congratulations to them. And of course, congratulations to all the participants. I'm sure there will be a cutthroat competition because as we can see, the position kept changing at every round. So must be a very small marginal difference between the other contestants. And of course, solving MCQ is an art. Sometimes your knowledge is equally important along with the art of solving the MCQ.
So congratulations to Anita, Deepa, and Ravina, whichever state you are hailing from. A good job. And then keep up the good work and continue to participate. And I'm sure as all 3 are women, please continue to contribute to the Win India activities and be active in Win India activities. So congratulations to all of you. The certificate of winning will be sent to your mail ID. and certificate of participation to every other person who has participated in the quiz will be sent to their respective mail IDs. So thank you so much. This is the annual quiz of 2023. So we hope to conduct a much more wider and inclusive quiz session in the forthcoming 2024. Before that, again in December, we have another academic activity coming up. So we keep you posted. Stay tuned to the Win India activities. Thank you. Thank you so much. Thank you, Sonal. Thank you for all the hard work that you have put into, and it's been amazing, learning a lot. Lots of points have been emphasized by you. Thank you so much. And of course, the tech team has done a good job. Thank you so much, Vipul and his team. Thank you. Thank you, everyone. Any final words, Sonal?
Thanks for the opportunity. I hope the students enjoyed it, and I'll try and make it more informative and more entertaining next time. Thank you.
Thank you. Thank you so much. Signing off. Thank you. Thank you, everyone. Thank you.
Thank you, ma'am. Thank you so much.
Bye, Sonal. Thanks, Vipul and team.
Thank you. Thank you so
Yeah.
much, ma'am.
Yeah.
Bye, ma'am.